I, Dr. Deepika Chabra, welcome you all to today's webinar. This is an initiative by the company's medical services wing to keep in touch in the present times of the COVID-19 pandemic crisis facing mankind. It is imperative we continue to do our best in keeping the fraternity informed about the changing scenario that will impact during and post-lockdown guidelines. Dr. Basu is an internationally renowned speaker. He is a specialist in diabetes and preventive cardiology from Calcutta and has an experience of over 3 decades in these fields. Dr. Basu practices at Apollo Gleneagles Hospital in Calcutta. Dr. Basu is President, Diabetes Awareness and Youth, through which he is involved in various community services. Formerly as founder and in charge of Sugar Clinic at Apollo Hospitals, he also serves as faculty and examiner for PhD students. He is principal investigator on 5 phase 3 and multiple phase 4 trials and many more observational studies. He has many published articles in international journals and has delivered several lectures at national and international conferences. Dr. Basu is chief coordinator of the prize-winning book entitled Living Well with Diabetes in India. He has authored an exclusive bestseller book, Diabetes and Musculoskeletal Disorders. He is a member of several reputed societies and associations like American Diabetes Association, European Society of Cardiology, Preventive Cardiology, Cardiology Society of India, RSDDI, among others. He is the recipient of many awards, some of which are the prestigious Professor Ibrahim Khan Memorial Oration Gold Medal at Dhaka, Dear Doctor Award by Citizens Forum of the Telegraph, and West Bengal Gunijan Samman. Today, Dr. Basu will be enlightening us about COVID-19 pandemic and its implications on elderly, especially in relation to CVD. COVID pandemic has become global public emergency and has affected everyone. He will be talking about problems faced by primary care physicians in management of elderly patients with CVD in the current scenario, and also how best to overcome and prepare for the future when lockdown reopens. You may also note that this entire we have close to about 250 doctors present in this webinar. I will now request Honorable Dr. Debasis Basu to kindly share his knowledge with all of us. Sir, a warm welcome to you.
Thank you, Dr. Deepika. In fact, at the outset, let me tell you how it all happened. One afternoon a week back, suddenly Dr. Deepika gave me a call that we are planning to do some medical programs. And the connect was a Calcutta boy, Tithankar, whom I know for years together. He has not only been a company man, from the pharmacy industry, but he's been working very hard for a cause, for the cause of diabetes, elderly, for the social work that we do here in Calcutta. He's very strongly associated. And because we are into academics and the organization name is Diabetes Awareness and Youth, our main objective is to raise awareness of a particular subject. Basically, knowledge is the issue. So that's the reason whoever is in touch, whoever that we come across, is supposed to kind of multiply that knowledge, that little knowledge that we have, and make it into bigger form. Now, that's how we connected. And this morning, suddenly I realized that I was not particularly in the right shape of my, my mind and body to have this program done. And I just gave her a call at 9 in the morning that can we do it a week from now? Somehow, because of so many of these webinars kind of rocking one after the other, it's like a storm. And it's not the, the coronavirus pandemic. It's actually the panic of the fear of the virus all around. The household is in a mess. People are, everyone is in a mood of aggression. Somewhere there's an anger, so much of suspicion. Even a son comes in, your little daughter comes in, granddaughter comes in, you want to give her a hug. But again, you're suspicious. Where has she come from? We never knew in 100 years, perhaps. I mean, I think nobody's living, from the days of the Spanish flu. So this is the first real, first-hand, real-world experience, as we, as physicians and trialists keep telling, of that serious pandemic. And may I start this message on a biblical reference, saying that all of these, like new diseases, when, in those days, Jesus, the leprosy, plague, they were coming. So it was mentioned that all of these were advanced patrols of a great army that is preparing out of sight. You do not know where they are being prepared, where they are engineered, not in China or in the US, but they are preparing. And they have come millions of years before us, only that we are identifying them now. So in 1960, we identified this corona. It is not in 1960 it has come. It has come millions of years perhaps before us. And the most important message is, scientists like Joshua Lederberg, who won the Nobel Prize for microbial genetics at the age of, tender age of 33 in 1958, in his Nobel Peace, that award-winning lecture, he said, and it is not a mere rhetoric, I tell you, he's made this statement: the single biggest threat to a man's continued dominance on the planet, apart from man, is the virus. And we have exactly come to a situation where this, virus that we can't see, that invisible virus has become invincible. And it is such a sorry state of affairs. My topic for this evening is COVID-19. COVID is the disease. Obviously, 2019, it was identified. CVD, cardiovascular disease, because we have come to know that people with this morbidity, cardiovascular disease, and people who are elderly and frail, and of course, people who have diabetes, uncontrolled diabetes, they are at the highest risk of not only having the disease, getting infected with the disease, but showing the symptoms. And the bad part is most of them are actually dying. So I will start this conversation with 2-3 statements which I feel from within my heart, that in the business of a busy life, we are forgetting our parents. And it is a mortal sin to discard the elderly. I have heard quite a number of times during last 1 month that coronavirus has come to just clear the garbage and put it in the trash can. Our parents who have crossed the brink of the 80s, they're actually waiting on the brink to go to the other side of the Baitarini River. Is it so? And if it is so, then perhaps we should not be the judges to do that. So this is some statement I want to make at the beginning. I want to make sure that people who do not cherish their elderly have forgotten whence they came and whither they go. So where you have come from and whether day I am aging. So where I'll go, perhaps a corona can come and cleans us off. That's not the method. So we must take adequate precautions for this elderly population as well. Virtually most of them will have CVD, cardiovascular disease, and we'll try to protect them. We must remember that these are the people, whoever they are, however they are living, if you go and sit with them, you will get to learn. You will get to have some kind of a knowledge. Old age is like climbing a mountain. You climb from one ledge to the other ledge. And the higher you get, obviously, the more tired and breathless you become. But their views become more extensive. And this was actually a statement made by the famous movie director, Ingmar Bergman. And he had a penchant for having an old man's shot, for 5 minutes, 2 minutes, he will have an elderly couple or an old man in his movies, in all his movies, which look like morbidity, but they were actually, those minutes that you spend in that movie will give you a lot of knowledge. So I will come directly to the presentation. Am I connected, Dr. Deepika?
Not yet, sir.
Not yet, yeah.
Screen share.
Yeah, screen share, I will go. We have to go for screen share. Here, share the screen. I've got it, yes. Can you see me?
Right. We can see you now.
And we have to go for the full screen.
Full screen, yes, sir. Slideshow.
Slideshow.
Bottom,
Yeah,
left,
bottom I know, but
right hand bottom.
bottom you are there. You have covered that. Not you, Vipin is there. Okay, so this is, let me tell you, the slides that you see, you feel like you are in a movie, in a matinee show. This is by Amit. Amit Saxena is there. I must, at the beginning, I will also definitely like to share with you, the audience, the August audience, that not only Dr. Deepika Chabra, Mr. Amit Saxena, and Dr. Bipin Tyagi, with whom I had a fantastic, relationship, father-son bonding, but with a fight in the morning. And of course, I should not forget Dr. O.P. Sharma, the Geriatric Society of India, the biggest man, Dr. Kaushik Das, and Dr. Anand Ambele, who are equally responsible to have inspired me to go ahead with this talk. So I will start with the current situation. We all know that it started in Wuhan, and the 80% of the population is asymptomatic. So suppose as medical professionals, we can all be carriers of corona, but perhaps we are not symptomatic. So we are not being, forced to go and get a test done. This is something that you should keep in mind at the very beginning. Maybe we are all getting, as carriers. And if that is so, then, God forbid, the herd immunity that Boris Johnson was, contemplating, unfortunately, before he was put in the ICU, will certainly happen. The 80% are asymptomatic. 15% will definitely talk about the symptoms, but they can be treated even from home. And 5% will need therapy, intensive therapy, perhaps in an ICU setting. The transmissibility is infected droplets, and we know if the droplets are heavier, more than 5 micrometer, then five micron, then it will travel for less than 1 meter. If it is less than 5 micron, it will travel for more than 1 meter. Now, scientists in MIT, they are saying that it can travel up to, we are talking about 6 feet, they're talking about even 13 to 17 feet. So we are not going to all that controversy, but, if you are otherwise trying to keep that safe distance, 2 meters is very, very safe. And the contact surfaces are naturally from locally it spreads. And if you're touching the fluid droplets, it's a hand and on the surface, like if it's a wood or it's a steel or it's your newspaper, every category has a time period of how long that the droplet will stick to it. So we'll gradually with time come to know about. And let me tell you, one good thing is that corona is a 3-month-old baby. So it doesn't know exactly what it augurs within itself, the fire of a demon, or the zeal of a Devi. We do not know, because we know that a lot of viruses have also helped mankind. This is not the way to start with, but you never know the mutations, the changes that are happening so fast because of our resistance to accept this virus makes things a little weary. But let me tell you that all of us are talking. So I am talking, Debasis Basu today is talking. He is no expert in corona. He is no expert in COVID-19. Only the people who had been at the bedside in Italy, in China, in the US, perhaps the emergency medical officers, have come to know exactly how the disease pattern is, how they are behaving, even at a saturation of, SpO2 of, say, 80, just, the lower 80s. The patient is otherwise cool. The patient does not seem breathless. Something is, different from the typical kind of a respiratory failure. Whether they're saying that the heme fragment is breaking up and it is the saturation level from the heme to the cell happening for the oxygen part, the dissociation part, we do not know as yet. But what we know is that this is really novel. It's not only new, it is novel. There is a novelty about it. So the second slide will be on the global and Indian statistics. We in India, we know, so can anybody tell us what is the present number the worldometer says? There must be, people who are constantly doing that, like as if they're in a stock exchange, worldometer of corona. The worldometer of corona now, let me just tell you, that's the advantage of this video conferencing. It says it is 2,656,680. That's the number of confirmed cases, and death is 1,85,192 deaths. And out of this, what we are apprehending is more than 50% of them are in the elderly age group. and perhaps, again, composite, cardiovascular disease, elderly, they will, and also diabetes, they will comprise around 85% of that number. So this is the risk factor which can actually exaggerate the chances of mortality. So these are old statistics. This is one slide which Vipin has put in. This is how every day the numbers are going. And now you'll see that after, see, this is, if you see the numbers are, this is 1st of April. So from 18th of March, you know, that lockdown phase, it was definitely locked down. But see, the numbers started growing, and it is state-wise. So are we really doing the lockdown is a big question from this particular slide, or whether we need some revision of our statistics, you know, basically strategy. Lockdown cannot be implemented until and unless the army is deployed. If the army goes and gives you food and you are bound within the walls, you know, almost by a lock and key, then that becomes lockdown. The moment you're released and you frantically go to a market for 1 hour to do that paranoia kind of a purchasing, then everything is shattered. So it's no point. Somewhere I believe we have failed, you know, in that real lockdown, the word of it, because see, look at the numbers. Now they're saying it, whether it's plateauing, and I don't believe my media. So please, sorry, I'm not being socio-politically correct or incorrect. This is my personal version. It's all about the hype. It is all about the noise and anything but the news. So the timeline is something very important. 12th December 2019, the first reported case from that seafood market, etc. It happened. And then World Health declared it as a public health emergency. It was on the 30th of Jan. And then 28th of February, World Health again said that the regional global risk is very high. And, you know, now things are moving that way. So what we are saying is in India, the median age is 37. Now this is a data which has been taken from the epidemic curve, but I can tell you the median age is actually 29, 30. So half of the population will be above that and half will be below that. So that half of that's 1.38 billion people. If they're below, you know, 29 or 30, they should not be at that higher risk. But whoever they are above that 30 will also be 70 and 80 will fall into that category. So let us see, you know, and the males are, you know, around 60%. But this is, I believe, because, you know, the women are being underreported somewhere and they are not coming out with even the flu complaints. So that's another issue. The 9% to 10% of the India's population are senior citizens. This is the statistics, a very good statistics. 103.9 million people are aged above the age, you know, 60. 8.6% share of the elderly of the total population. This is what we are observing. And we know that if you are more than 80 years of age, it is almost 15% you have the risk. Sorry for the spelling. More than 70, you have got 8% of the risk. And men, women, this is the division or of your gender in the age group category. Coronavirus can overwhelm the body with age. Elderly have weakened immune system, which is of course, again, further weakened by chronic diseases like diabetes, hypertension, COPD, cardiac issues, renal state, poor impaired renal status. Now, all these factors, especially aided by frailty, which is age, contribute to the overall stress of infection in the body. In all our cells, we have something called a self-motive. We have a pattern in the cells. And the self-motive is my motive. And suppose there's a pathogen like, you know, the SARS-CoV-2. It is a non-self motive. But as we are talking constantly about so much of hammering of, you know, corona, so much of, you know, negativity about life, so much of escalating horrible numbers, our body is actually, the self-motive is changing into damaged self-motive. And that causes inflammasomes. Now, these inflammasomes almost are akin to the non-self-motive pathogen-like materials. So we become virtually prepared as self, but damaged self, welcoming a slightest of infection to put, you know, fuel on the fire. So that is exactly what is happening, especially in the elderly population. We are seeing that they're very, very anxious. They're not anxious of their own lives, I believe, most of them. They're very worried about their children. There's a layoff, there's unemployment. Somebody is stuck in the US. The grandson is gone for education. One day the phone call is not there. The inflammasomes are multiplying. They're boiling. And this gives us to the potential, the picture, the horrible picture of the disease itself. And we know that many elderly in China and Italy had a huge elderly population. They died due to the cardiovascular problem. Sepsis, septic shock was very important, without any sign of lung involvement. So what we are talking about ARDS and secondary to pneumonia in the elderly population in Italy and also in China, they showed that instead of lung infection, it was a blood-borne infection happening, flaring up the disease. So that's what I'm trying to tell you is the poor immunity status, or whether the humoral immunity will come to it altered, it is the problem. People who are at higher risk, people who are immunocompromised, like somebody is a cancer patient, somebody is a transplant patient, somebody is getting steroids for some reason. People with chronic lung disease, heart disease, diabetes, and chronic liver disease. People who live in nursing homes or long-term care facility. We don't have this nursing. Actually, the nursing homes that we talk about in India is not the nursing home in the UK. Nursing home in the UK is a residential place where the elderly, if they don't have children, nobody to take care of, it's the government's imperative to put them in that nursing home setup where everything is given to them. And this is a place where you will stay for your life till death. So you are mentally prepared as well. But in our nursing homes, you go for a treatment, come back. And this is not what we are talking about here. I'm talking about, suppose you are an elderly man, you don't have a family support, you go to an old age home here. So I'm talking about that place. So there the elderly all collect together. And if there is a kind of an infection in somebody, the contamination rate is very high. And finally, it's a 65 years and above. And we know routinely, as a practicing diabetologist, we have been immunizing our patients with diabetes, PWDs, who is above the age of 2 with pneumonia and influenza. And perhaps from next year onwards, we'll be doing it for every year, the annual change strain of corona as well. Now, the physiology. The elderly population is more prone because there is a physiological decline in the functioning of respiratory system. They cannot do this. Restriction, FEV1, FVC, all is restricted. Decline in the functioning of the immune system due to immunosuppressive conditions associated. Lifestyle and personal habits, basically staying indoors, breathing the same room air. Lack of exercise. Breathing exercises are not there. A lot of people, even in the elderly, they smoke. There is a good amount of alcohol use, and that has become an abuse in the first earlier few days of the lockdown, but people ran out of stock, I believe, and the bars didn't open and the stalls were shut. But in West Bengal, I think it was stated that for 2 hours, there would be home delivery service of alcohol. Thankfully, in 2 days, that wasn't there. Then the therapeutic, if you are a patient with chemo, ongoing chemo, all these chemotherapeutic drugs, you are on a steroid for some other reason like arthritis or COPD. For immunocompetent patients, but suffering from comorbidities like diabetes, coronary artery disease, cardiomyopathy, uncontrolled hypertension, yes, the case fatality rate from Wuhan and China, they started sharing the view that people with hypertension died more than diabetes, hypertension and CVD. And that was true, and that still holds good, I believe. Chronic renal failure and chronic pulmonary disease. People suffering from OSA, obstructive sleep apnea. Now we know for that, one bad thing is that obstructive sleep apnea is the other name for sudden cardiac death. It actually heralds diabetes, it heralds hypertension as well, and heart failure. And these people are prone to nocturnal aspirations as well. People who have higher incidence of drug resistance owing to repeated and injudicious use of antibiotics. In our country, we have this habit, and it's a bad practice, that if somebody gives you a call and you are the PCP and says, I've got a sore throat and I've got a fever, low grade, immediately we are tempted to write to him an antibiotic. Say, for example, azithromycin. Macrolide is safe, whether we write an amoxicillin, clovulanic acid, whatever, we immediately jump onto writing an antibiotic. And this gives rise to, and that too the patient will have for 2 days. The fever is gone, patient is happy, healthy, hearty, and he will stop having the medicines. And the antibiotic strain will change, there will be resistance, and this is happening all across the globe. And World Health has specifically pointed our country, or this part of Asia, to be the culprit in owing resistance to antibiotics. Now, this is the immunology of aging. I will dwell on it a little bit. This is immuno senescence. It's any organism ages. And we know that it affects both the innate, the immunity with which you were born, and the adaptive immunity. Suppose I'm living in a slum, there's too much of dirt and smoke, and I've been able to live with it for the last 50 years, so I've adapted. But you come from a very posh place where you have not seen dirt, felt dirt, even smelt any smoke. So you have come to my area and you immediately will catch an infection because your adaptive immunity is not prepared. Then, there is so much of oxidative stress. That TV news that I'm talking about gives you oxidative stress. And that is the major factor of accelerated aging, possibly due to an increased pace of telomere shortening. We have this, if you look at the chromosome, and then the last bit of telomere, as quickly it falls, it's clipping, your age is shortening. So due to DNA damage. And this is epigenetics, this is histone and methylation, etc. A lot of things happen here. And also pollution, everything. Innate immunity is the immune response through several cellular components like our own macrophage system, the natural killer cells, the neutrophils. They come and try to attack the offending agent, like for a virus or a bacterium. They will come, and that's the first line of defense against the pathogens. But this function actually declines with age. And the quality of humoral, that's a bone marrow derived humoral immune response, also declines with age. There is a decrease in diversity and functional integrity of both the CD4 plus and the CD8 plus T cell subsets, which contributes to a decreased ability to respond adequately to a reinfection. We are seeing a lot of reinfections from corona happening in China again, and they're specifically the elderly population, and on some alcoholics and smokers. And mind you, in this setting, let me tell you, the smokers have 14 to 15 times higher risk of getting affected with corona. So perhaps this was the best time to quit smoking if you have, or perhaps the government could have come forward with some nicotine replacement therapy and completely banned the smoking, like they have stopped the alcohol, the liquor shops, all the cigarette shops, the pan biri shops, then something good could have happened to this country as well. And among these, it is primarily the adaptive immunity and the T cell subset, which is most susceptible to the deleterious change, especially with the involution of the thymus gland by midlife. The thymus actually starts shrinking, and the T cell subset comes from here. There is also hormonal influence. People, because of the aging of any cell, even the beta cells are aging. So chances of your diabetes, hypothyroidism, adrenal dysfunction, everything sets in with age, and the person becomes increasingly susceptible to infection. See the diagram here. They talk about thymic involution, the overall changes in that telomerase activity, the tumor incidence, etc. The inflammaging, see the cytokines, IL-6, C-reactive protein, they're going up. The B lymphocyte pool, which is a protective pool, which is naturally the naive B cell pool is kind of going down. The memory B cell pool is upgraded, so you have some remnants of what you had in the past. So that's the reason how we survive. That's our intrinsic mechanism. The T lymphocytes, it's also the same, and the CD4 count goes up. The CD4 count comes down, and the CD8, like exactly what happened in AIDS. And finally, we have the COVID pandemic, which is causing, it typifies the immune response of an elderly person, the rapid rate of spread of infection, delayed immune response even to medicines, etc. All is because of this low immunity. So the person is vulnerable. Just a second. The pathophysiology is, therefore, the reduction in synthesis of T and B lymphocytes, as well as impaired IgG synthesis, impaired phagocytosis, that's the bacterial engulfment, and the defective clearance of the secretions. You have that, whether it's a parasite or a bacteria, you engulf it, put it in your vacuole, and then you have no mechanism to throw it out as a byproduct. And that's how the Plasmodium parasites are engulfed in the blood cell. So data indicates that COVID-19 viral infection is capable of producing an excessive immune reaction called the cytokine storm. You have been hearing about this. This is nothing but sudden surge of all these interleukins coming out. And if you're not prepared to handle that, the response of the virus does not give you the graded, stage-wise, a symphonic orchestrated movement of the cytokines, but they will throw it one after the other like a tsunami, and the body will go into that storm. So that gives you that ARDS flare up, etc. SARS-CoV-2 attacks enough alveoli in the lungs to cause that fluid buildup, and finally they are actually like vacuum or air-filled grapes. So you have the inner lining, you are getting inflamed. So those cells stop, they secrete a lot of fluids, and the fluids accumulate in the base of the alveolus. And so the exchange that happens in the capillary is now filled with the fluids. So the exchange doesn't happen. And that reduces the oxygen, finally, the oxygen carrying capacity to the RBC. The clinical syndromes we all know, it's mild illness, pneumonia, severe pneumonia, acute respiratory distress syndrome, sepsis, and septic shock. The clinical classification is, one is asymptomatic, you don't know anything about it, you can't feel anything about it. Mild disease, uncomplicated respiratory syndromes, one sneeze, one cough. Severe disease is dyspnea, hypoxia, and more than 50% of your lung is involved on CT, or on X-ray or CT, whatever, within 2 days. And the critical disease is respiratory failure, shock, or multi-organ dysfunction, which can become fatal. And 1% of the population, we see that they will die if they are dying in this kind of a state. The treatment protocol for the elderly is that all elderly with COVID-19 positive should be treated naturally as the high-risk category, immediately admitted, and observed for complications. The management of ARDS, we all know, supplemental oxygen, instead of elective intubation, but primarily with the CPAP and BiPAP, if you can do, unless you are forced, don't use the mechanical, the ventilation. That's what is said. Avoid nebulization, use low-dose prednisolone or tocilizumab, which is an interleukin-6 monoclonal antibody if there's no contraindication, and you can use azithromycin as well. Management of cytokine release syndrome in older patients with multiple organ dysfunction is that cytokine release syndrome grade 3 can be monitored by those markers, IL-6, C-reactive protein, ferritin. Consider this tocilizumab, 8 milligram. We don't get into the details of all this. If no response, 2 more doses are 8 hours apart. Consider low-dose steroids, methylprednisolone to start with for the septic shock. Use antibiotics for possible septic shock. Fluid resuscitation is a must. And noradrenaline if the patient is having vasomotor collapse syndrome, so you give him all the inotrope support. High interleukin-6, high rising CRP, hyperferritinemia, elevated. When they become elevated, you must be very, very cautious. The patient perhaps is sinking, so take adequate guard. The treatment protocol for elderly, as it continues, for mild, you just give him an azithromycin. That's for, they say 500 for 1 day, we say 500 for 5 days. Some amount of anti-inflammatory paracetamol, etc., antitussives, antihistaminics. The B is the severe one, where People are now talking about the hydroxychloroquine, 400 milligram twice a day for the first day, and then 200 milligram twice a day for 4 days, plus azithromycin 500 milligram once and 250 milligram for 4 days. The oseltamivir 75 milligram BD. We had the bird flu time. We had Tamsulovid. Now we have oseltamivir, which is given for 5 days, or until the COVID report comes or the influenza symptoms are predominant. The things that you need to check here is when you're giving azithromycin, check that the patient does not have regular GI problems. Then that will aggravate. The azithromycin also can cause QTc prolongation. So smaller doses are talked about when given with hydroxychloroquine, because that has also a propensity for arrhythmia. We check the baseline retina before we start on a hydroxychloroquine, but because it is short time, low dose, we should not really bother, but why not do a test beforehand. The patient has epilepsy or treatment for myasthenia, then we should be careful. Category C is the severe category, where we talk about this lopinavir and ritonavir. The trials are going. The solidarity trials have started in Norway. The first case was recruited in Norway. The 4 different groups of drugs are being tried. Now, we need to have trials on this particular disease, and that's what has now, now being taken over by almost 45 countries, and India is also a part of this solidarity trial movement. The do's and don'ts for the elderly. All elders should be encouraged to practice social distancing, diligent hand washing with 60%, 70% of alcohol if required. If you run out of soap and water, don't run out of this. And respiratory hygiene. When you're covering your face, sneezing or coughing, and coughing to the crooks of the elbows. And then kind of don't rub it anywhere. Try as much as possible to go back home. Don't also keep a safe distance from other people. Avoid touching the face regularly. Even the eye secretions from the eye. There is conjunctivitis also from corona. It has been talked about. So as much as body fluids connections should not be there. The individuals who are caring for patients with suspected or documented, say for example us, should wear that tightly fitting medical mask. And I think we all have this. This is what we are all having. And, this is the the gloves every time. These are the paper gloves. This is the gamcha, the cotton gloves. This is the PPE. These are the gloves that we are wearing. So we must be adequately, as healthcare providers, adequately geared to take our own protection. Don'ts for the elderly. When you are doing this chemoprophylaxis for hydroxychloroquine, take care of the cardiac arrhythmia part. And also there is a big role of chloroquine or hydroxychloroquine in diabetes management, in taking care of the insulin degradation or the insulin dissociation from the receptor. Happens quite fast here, and quite slow here because of the basic content of the drug. So the insulin is stuck in the endosome, and the action is prolonged. So we see a lot of hypoglycemia in these cases, and if they're not eating well, malnourished, etc., in this kind of a situation, be careful about that. Wearing a mask, if you're people who are at home, they do not particularly feel like wearing a mask. If the husband and wife are there and they're virtually asymptomatic, there's no problem. Why would they wear a mask? They shouldn't. But if there's anyone who is coming in to drop even a food, or their laundry is somebody's coming for laundry, some janitor is coming in, try to avoid them as much as possible. But if they must be given a mask, and at that time the householders should also wear a mask. Do not ever self-medicate. Please call us, or whoever is your healthcare provider, and make sure that if you had a routine visit in a certain hospital, don't push to go. Talk to the doctor, because there's a lot of telemedicine happening these days. And if it's not an emergency, don't go and mix in the public crowd. The there are, these are the socioeconomic issues all over the world. And there are these very sad news which came from Italy. They kept the elderly completely out of the treatment because they were not insured. And so they were actually, how many died, we know that. In Spain, the defense minister stated that death and abandonment of the elderly. He clearly stated that okay, they're old and we can't manage them. So we raise our arms. The news was so shocking and disgraceful that affected the health of all the elderly everywhere they came to know, and that contravened the human rights and the UN principles for older persons. And this is very saddening. This is why I started off with those comments at the first slide. The national economic issues, socio-economic, the mobility. Because of the lockdown, elderly cannot go out for a walk. They cannot attend to any health facilities like nursing homes or their polyclinics. The financial, even going to the bank, for transactions, etc. And that is actually affecting their health also significantly. The procurement of essential commodities. Though everybody is saying very loudly that there's no dearth of essential medicines or commodities, but we are facing, if you're an elderly person almost locked up in your house, and you're not supposed to go out, and you're feeling that core anxiety within, then it becomes very difficult. And we are seeing day in and day out, because from our organization, Diabetes Awareness and You, let me tell you, ladies and gentlemen, that for the last 1 month, we've been going to door to distribute medicines, if required food, to not only our beneficiaries, to those 60 people who need insulin and all, the type 1s and the type 2s, virtually burnt out type 2 diabetes, completely dependent on insulin. But we are also doing it for people, any other patient who are on an insulin pump but not getting the consumables, and the quick starters are gone. We are trying to go to their house, reach the products and the supplies, and our educators are constantly in touch to monitor their insulin dose, and we're giving them glucometer strips adequately. And I'll take this opportunity to make sure that all of our patients should have a minimum of 3 months stock. I was talking about a 1 month stock, till 2 weeks back. Now with things kind of, every day things and numbers are changing, and our opinions are also changing. So there's no harm in hoarding your life, right? And insulin is life for type 1. So you adequately can have a 3 month stock. You are actually not jeopardizing somebody else's insulin reserve. So don't feel sad. Have your own stock, live first. So this is not socially responsibility. This is taking your own good care. And then you can take care of others as well. The preparation and the supply of food. Cooks and maids have been barred to attend the houses of their employers. So these people, elderly people, are finding it very difficult to cook their own food, who were not used to. And their nourishment and nutrition is suffering miserably. As I was saying, the availability of medicines, where insulin 2 weeks back was in a bad shape in Calcutta, and we were reaching out insulin, as I said. And the good thing is that the government, I believe, in 3 days back, has promised, or this is unofficial, but said that there will be no dearth of insulin, and people will not, like the lack of oxygen or air or food or water, will not die from insulin. That was our claim. We were shouting about it, and I think we are raising our voice to be heard nowadays. So this is where because the elderly have so much of polypharmacy. For every little thing, whether it's a gas or a constipation, they are dependent on medications. And if you don't have a Dulcolax at home or a purgative at home, you will not go to the loo. You will not go for your toilet because you'll feel that you're constipated. There's everything in the mind as well. So once you have a bottle on the rack, you'll feel comfortable and your bowel movement will be normal. And this is how the elderly behavior is. So we must adequately pay regard to that. And of course, the financial issues. If you're a daily wager, or if you're not going to the bank and you don't have those ATM facilities, and you also are apprehending to go to the ATM counter, it becomes difficult. So from the organization, again, we are also helping people to get their checkbooks, etc. The bank things also we are doing. This is the proposed measure for the elderly patients. Now, the United Nations said that open-ended working group on aging for the purpose of strengthening protection on the human rights issues for elderly persons. State and central governments are also making aware of the emerging situation. That will appeal to inform all the machinery to remain vigilant on these issues. And NGOs and social workers are also come to the forefront and the work. The lesson from Wuhan was the new infection was brought under control because of quarantine and isolation. In India, we have, like China, we have a huge population, and one family may have several members. So the chance of cross-infection remains very common. And we need to have this testing is a key debatable issue. We must have adequate testing kits and the facilities. Whoever is being suspected of COVID-19 should be immediately screened and tested. So that is very important. And if they are positive, then the isolation should happen, and the breakdown, that is how the transmission we can break down. The older adults, we must know that there are certain points in older adults. How elderly can reduce risk of getting sick. Advise they to stay home. I'll come to these in the last few slides. This is how CDC has developed a care plan. So I will show you the care plans, the picture of it, how they have emergency room numbers for the nearby hospitals, their doctors' names. So this is the care plan format. You fill it up, and your local authorities, your panchayats, or your councillor can have an access to that. Give him a call, and he has everything on his, on his hand, and he can immediately delegate and get things done. Deaths, we are very sad to say that in the US, more than 65 years, 8 out of 10, 8 are dying. Even the population, they're saying almost 95%. The even countries that people are dying above 60 years of age. And in India, more than 75 of the COVID-19 who died were above 60 years of age. So that's the issue we are stressing on this talk today. About SARS and COVID, and the COVID-19 and the heart, I will just talk about briefly that the acute myocardial infarction was the cause of death in 2 of the 5 fatal cases of SARS out of the 75 patients reported to have the disease. These are tachycardia was a common finding. A study from Singapore said that pulmonary thromboemboli, and we are seeing that D-dimer level is going up, like lymphopenia, neutrophil leukocytosis. There's D-dimer which is going up, and we have realized that there's some break happening in the heme on the globin part of it, of the blood cell, as well as the emboli are taking shape. So DVT is occurring, subendocardial infarction is happening, pulmonary embolism is happening. So these are the, I will not touch upon the MERS part of it, but in Saudi Arabia 2012, when MERS came, they also, they stated that 30% of these cases had underlying cardiac problems, 50% had hypertension and diabetes, 16% had obesity. And the presentation of COVID-19, heart-wise, I will not, this is the general, we have all known about it. Only the point is, if you're an elderly, your chances of those typical respiratory symptoms may be less. It's only the dyspnea or the breathlessness which will be more. The importance of myocarditis, there has been fulminant coronary myocarditis reports, even as a 37-year-old boy. And this is because of the toxic products that Cytokine Storm, and maybe, and the cardiac injuries have been shown because cardiac biomarker, the NT-pro and BNP, that was very, very strongly positive. So this was typically myocardium, as we have in heart failure, the myocardial cell, the brain natriuretic peptide, the atrial natriuretic peptide in the muscle layer of the heart that showed up, myocardial injury. And a lot of people dying from that. This is a beautiful slide sharing us the potential mechanism of the acute effects of the COVID. The viral infection is happening there. On the top, that's a coronavirus. Look at the corona, the crown. So what is it causing? It's causing a cascade of events. One is a direct vascular infection. So as I said, sepsis, the problem is in the blood. The more vascular and cellular inflammation, the cardio, and if the patient is elderly, already has an underlying coronary artery disease, has had a bypass or a stent, So his risk is more. If you have the viral infection, the systemic pro-inflammatory stimulation is there, which is the cytokine storm. If you have associated diabetes, diabetes itself is called a pro-inflammatory disease. So over and above that, that will be a problem. Hypercoagulability. The hypercoagulability is causing, stroke, heart attack, pulmonary embolism, and DVT, pulmonary embolism as well. There are evidences of plaque rupture. So you have a stable plaque inside the intima, and suddenly there has been a cascade of events, and so much of ICAM, VCAM, selectins were liberated that the endothelium got disturbed. And if you have an underlying endothelial dysfunction like diabetes, it suddenly ruptures and all the platelets come and they clot and you have a heart attack. The sympathetic stimulation is increased because every time you are excited, so much of adrenaline or adrenaline coming into the circulation because of those stressful news coming from all around. And of course, the infection proper. The myocardial oxygen demand will be now higher because of too much of pumping from the heart, and that will cause heart attack. Then the acute respiratory distress syndrome, superimposed infection will cause hypoxia. So again, myocardial oxygen supply, the supply demand of oxygen will be now distorted. More sympathetic stimulation, as I was saying, the more oxygen demand, and if you have a failing heart, then that will cause frank heart failure. Pro-inflammatory cytokines, myocardial depression, direct myocardial infection, and some myocarditis. If you have myocarditis, pro-inflammatory effects, and the sympathetic stimulation, you also have an excess arrhythmia risk. So finally, at the end of the spectrum, you have heart attack risk going up, you have heart failure risk going up, and you have arrhythmia risk going up. So be careful of the medications that now you will give for COVID-19 management. The acute complications are, as I said, all these. And in this kind of a heart failure quick setting, you need perhaps an ECMO or a VV or a VA ECMO to give you the support. The other complications are, the implications are that you have to plan to identify the disease, isolate the patients properly. The underlying CVD causes have to be cannot be eliminated, but addressed immediately. The additional precautions to be taken under whatever guidance or guidelines we have in our regional places. Patients who were not vaccinated for pneumonia can, during this time, if they are not affected with any disease, get away with, should not get away with that lack of vaccination, should get it as an opportunity. Pneumonia and influenza vaccination should be done. Telephonic consultation should be done as much as possible. We have so many tele platforms, and all the pharmaceutical are helping us to develop our own platforms, our own kind of web page where we can be like brand ambassadors talking about health with our patients. The triage is very important. For every patient, you need to have an underlying disorder triage. Whether you have a kidney problem or a heart problem, your ECG baseline should be done. Your creatinine status should be talked about, because now when you're giving drugs, you should be careful about on what setting you're actually doing justice to the patient. Right dose of fluid, you can't precipitate a heart failure because these patients might be in an impending heart failure situation, so be careful about that. And if you are otherwise a caregiver or an associate of the patient, you should actually eat well, sleep well. Sleeping has become a mess because so much of screen time and so much of desperate isolation, depression, etc. That we have lost the circadian rhythm, that the chain has broken. So now we should have a wake up time and a wind down time. We should go back to the same bed, typically as we used to do in our otherwise routine life when we used to go out. So the cardiac specific recommendation should be that cardiovascular care team is a different team. If you will not delay, if you have a heart problem, if you have a heart pain, which looks like any kind of discomfort, because you will be apprehensive to go to a hospital and catch a corona, you will not go there. You will delay the process. And from a non-STEMI, you can have a STEMI, and you can have a scar of the myocardium, where an angioplasty or a bypass will also not suffice. So don't waste, that time is critical. That golden hour thing you don't miss. If you have any discomfort during this stage, whether you have diabetes, whether you have hypertension or underlying cardiovascular risk factors, just rush to the hospital. Corona, don't worry about corona to infect you, because you first should live, then we'll think about corona coming and doing some harm. This is that pathway that I'd like to talk about in this context, that angiotensin, the RAS, the renin-angiotensin-aldosterone system pathway, and the SARS-CoV-2. See, this is the cycle, the angiotensinogen broken down by renin to angiotensin 1. Now, angiotensin 1 is broken down by the AC inhibitor by the AC, the angiotensin converting enzyme, to angiotensin 2. Now, angiotensin 2 directly acts on angiotensin 1 receptor, which it causes inflammation, fibrosis, all the bad things. It is notorious, that receptor gives the casket of bad things. But angiotensin 2, with the help of AC2, the angiotensin converting enzyme 2, is broken down to angiotensin 1 to 7. Now, this gives you to the mass R, which is actually gives you the anti-inflammatory, anti-fibrotic cycle, a completely alternate, exactly not the alternate, the reverse of the 81 R mechanism. So good things happen from here. And now you see SARS-CoV-2, when the AC2 is overexpressed, SARS-CoV-2 comes and attaches with the AC2, whether it's in the lung or any other epithelial cell, kidney, wherever. And in fact, for COVID-19, we see that it's mainly the lung and the kidney. So these two organs are more affected. And also it is happening in the brain. But that gets affected. So what is happening is AC2, which is overexpressed, is getting blocked by SARS-CoV-2. So what is happening is the next slide will show that. So the SARS-CoV-2 is zoonotic, whether it came from bat or whether it's for MERS was camel. So the initial symptoms of fever, fatigue, dry cough, body pain, diarrhea even can happen, dyspnea. The lower SpO2 levels progressively, pneumonia-like symptoms, evidence of lung damage, and prevention is adequate hygiene practices and social distancing. Management we all have heard about. Life cycle of the, yes, now we are coming to that, the glycoprotein, you saw the the spikes, then the P proteins and the glycoprotein, the corona effect. The human cell surface has the AC2 enzymes. The AC2 acts as receptor for the SARS-CoV-2 to launch the first attack, the entry point. It fuses with the cell surface and releases a genetic material, like for any virus. Virus itself is not living, but when it comes to a living animal, it will transmit the viral particles, the genetic materials, and they will the fission will happen, and no new progeny will form. The replication itself is own cell's molecular mechanism. Now, see, this is the picture. That's the SARS-CoV-2 AC2 receptor. Then the fusion happens, uncoating, and the genomic RNA. This is an RNA virus, we know. It now starts replicating, and that is how the chain is formed. From the translation, you have smaller viral release. So they will, out of one, you'll have many. Like out of one, you can transmit to 3 to 5 people. That's your, we have a R naught. What is your reproducible category? That one virus can do damage to 3 people, 4 people. So here also, from one, you are having so many. But the affection is with the AC2, where the ligand is getting attached there. So that's the cellular point of entry, and we have finally multiple viral copies. So this is the AC2 host. Now we will tell you this mechanism. The increase in angiotensin 2 following the AC2 internalization may exacerbate the pulmonary damage initially provoked by SARS-CoV-2. So what you saw, angiotensin 2 gives rise to angiotensin 1 to 7, which is a good molecule, which gives you to the mass receptor. So that is a good molecule. But here in this case, because it is getting occupied by the SARS-CoV-2, the angiotensin 2 part is now growing, and it is not being able to convert to AC 1 to 7. And what is happening is, in turn, the reduction of AC2, that contributes to a loss of pulmonary function and increased tissue fibrosis due to COVID-19. The extent to which SARS-CoV-2 infects the heart and the cardiovascular tissue, also this kind of a mechanism can contribute to the myocarditis as well. So, but this is unknown. Cardiovascular tissues or cells can express AC2 are potentially at risk of SARS-CoV-2 infection. Cardiovascular cells, so same, I'm sorry, that's a repetitive. Now this is the slide I want to come. See the older patients, we are with the elderly. Older patients with documented CVD, they have lower AC2 levels. Therefore, they have high angiotensin signaling. Younger patients without CVD, they have higher AC2 levels. Therefore, they have lower angiotensin 2 signaling because that has converted to angiotensin 1 to 7. Now, in both of them, if they have COVID-19, older patient with CVD, younger patients without CVD, SARS-CoV-2 will bind to the AC2, leading to reduced AC2 cell surface expression. The infected older CVD patients with, they have critically low AC2 levels. So therefore, they have exaggerated angiotensin 2 signaling, the one on the left. That will now, so more of inflammation, no more of fibrosis, etc. So likely lower incidence of disease, COVID, they might have lower incidence of COVID, but very higher severity. So because they have low AC2, much more number of corona cannot get in entry. But whatever entry it gets, because the angiotensin mechanism gets so highlighted, because of the angiotensin 2, the disease severity will be high. But in case of infected younger patients without CVD, because of that modestly low AC2 levels, the SARS-CoV-2 bound to the AC2 has now become, overall AC2 level has come down. And because that has come down, there is a little bit of modestly elevated angiotensin signaling happening on the left. So therefore, the patients will have likely higher incidence of the disease, but the severity will be low. So they will perhaps remain silent or asymptomatic. So that's the beauty of this cascade that I wanted to share with you. So how can the reduction happen? Whether it's a treatment of ACI or ARB, which is harmful for elderly, I don't believe this. And I will tell you that if the patient has heart failure evidence, never stop any medicine which he was having, ACI, ARB. In fact, on the contrary, mind you, ACI, ARB on the contrary, for the elderly will actually do good because the AC2 expression will be, in this case, more. Unlike in elderly, where the AC2 is low, if you are giving ARB or AC, then AC2 becomes naturally overexpressed. So there might be, coronavirus affection can be more, but the disease severity in the elderly will be less. So that's my understanding from this mechanism. So older persons with CVD will be exposed to more predisposed to greater disease severity in the context of COVID-19. But if you are giving ACI, ARB, there are papers coming in that for COVID-19, for SARS-CoV-2, perhaps the AC2 binding will have a protective role on the angiotensin 2 antagonism against the sepsis-associated acute lung injury. There are papers in mice model with SARS-CoV-2 that given losartan, that attenuated the lung injury. So there are, understanding problems somewhere. But if you ask me, I will not encourage stopping ARBs and ACIs from elderly patients with CVD. So finally, keep yourself well. First and foremost, you need to know that your hand washing 20 seconds more, avoid crowds, washing your, keeping a protection with your elbow, or you're wiping your face with a tissue, putting in the clean or a closed bin, important. Do not touch the most touched surfaces in your home as well. Practice social distancing, but not social isolation. Be together in terms of your, whether you're on the mobile or whether you're on some social media, or you're doing your own, playing your own games, Sudoku, etc. You can talk to from your veranda or balcony. You can talk to, milk vendor or who is passing by. a hello and a kind gesture can help. Technology, we have enough. The apps are there. We need to have everybody involved. Whether you are making a good food or you're taking your old photos out, doing a memorabilia together at home as an elderly. These are the following rules that if you have these symptoms, yes and no. If yes, then these are the questions. So we will share this with you. So this can help you guide as to how, if you are diagnosed with novel coronavirus, what are the things you expect? The answers are here. Whether you have pet at home, whether you would allow the pet to come to your room if you are diagnosed positive COVID-19. What are the symptoms that if you see at the earliest, you will take your own call. All the questions and answers are finally at the end. And I'll just rush through them so that you have a glance of that. Basically, it's all about practicing good hygiene. So from now onwards, the best thing that is happening to us is we'll become very consciously practicing good hygiene. And we'll perhaps become mask men, or that film The Mask, where Jim Carrey wore the mask and he was actually ravaging the tormentors. We will ravage our corona wearing a mask always. For perhaps 100 years from now, our progenies will be born with a mask also. So the greeting of the day, every morning, wake up, be grateful that still you are alive. The morning sun is out, and this 4, 7, 8. Take a deep breath for 4 seconds, hold it for 7 seconds, and then release it out for after count 8. And then that actually resets the autonomic nervous system. This is from the yogic practices and from JAMA and not from any other journal. So it makes sense. And also published in Lancet. So eating well, eating good food, etc. Phytonutrients, the colored foods. And finally, don't miss out your scheduled medicines and avoid going out, all on your own to buy your medicines. So finally, we have come to the last slide that, this man is, see how fit he looks. He looks fitter than you and me, perhaps, and he will survive, and we will help them to keep fit and fine. Thank you. And now we'll come to the questions. So open our masks and talk.
Okay, so I would like to sincerely thank Dr. Basu, first of all, for taking time and the immense knowledge that he has shared with us today. And I'm grateful to all the attendees for their presence, because without their presence, this initiative could not have been possible. And I'm sure with your continuing support, we will go a long way in knowledge sharing. Your active participation is truly appreciated. So I would like to reassure Dr. Debasis Basu our extended support in his future endeavors in the service of medical advancements. And now we'll open the session for one-to-one questions. So to ask a question, you have to raise your hand, then your audio will be enabled and you'll be able to speak out the questions. So first introduce yourself and then speak out, please. So I see 3 hands raised, and meanwhile, we'll take the questions which have come in the chat box.
Yes.
There's Dr. A.K. Gupta. Why not promoting HCQ as treatment guidelines, because study has shown it doesn't help in COVID-19 prophylaxis as per FDA guidelines?
So the question is, why not promote, or why are we promoting? I mean, why is this wonder drug, according to Mr. Trump, who said that this wonder drug will heal America in a compassionate way? I have my serious reservations, because I can tell you a lot of these, not anecdotes, but they are serious papers which have come in sharing that, HCQ has taken the population, not the elderly population, but a huge chunk of the population into that arrhythmic storm. So people have died miserably from heart complications, number one. Number two, the other point is the escalation of respiratory support. People who were treated in France were compared and with high dose of HCQs, and they said that nothing changed. In fact, they had required more respiratory support. And in fact, the neutrophil lymphopenia, the ratios didn't alter. So I have, I understand that HCQ acts, if you know the mechanism of how it acts, HCQ will act on the endosome. When the virus, you saw that picture where the virus was getting connected to the SARS, the AC2 and getting inside. We can go to that slide if we have. I do not know, Dr. Deepika, how we can show that slide. But there, the endosome, it will go down and, the multiplication, the replication, where whatever happens, that genomic material transmission HCQ stops. But, at the end, what happens is, I can, in fact, Dr. Deepika, what I'll do is...
Would you like to screen share that slide? I would not be able to pinpoint which slide that is.
Nevertheless, the basic understanding is HCQ has a role in fighting the infection of a virus. There's no doubt about it. But if you're talking prophylactic, the inflammasome state, why will you do that? And number two is in this, this is a country of malaria where we live with the support of HCQ and chloroquine, right? And if and these are all actually anti-apoptotic drugs. If you have this, why do the whites come to India and tell that you natives, don't you have chloroquine all throughout the year? But they are given, the quinine derivatives because that remains in the bloodstream for one tablet will stay there for 40 days, and the parasite will not be able to come and if you are a parasite, they're going to the blood RBC, the RBC will engulf you and you will die. The parasite will die. Normally, if that replicates and it goes beyond the number of the blood cell again engulfing it, then it will come out, go to the liver, and the whole malaria cycle happens. If you are anti-apoptotic drug is already there in the body, these parasites, malaria parasites will change. And we have so many mutant, we have chloroquine resistant malaria, we have hydroxychloroquine resistant malaria. So aren't we inviting, by giving willy-nilly, distributing the medicine to one and all, whether corona will ever come to them, affect, touch them in any probability, but there's 100% chance that in India, dengue, malaria is rampant. So perhaps they will die, unfortunately, of a hydroxy or a chloroquine resistant malaria, and the corona will never touch them. So these are the areas where we need to be very careful.
Right. Dr. A.K. Gupta, if you'd like to say something, you're allowed to speak.
Doxycycline could have been tried. It has worked wonders in MERS, the innate immunity part of it.
There's another question, Dr. Anshuman Kamal Bhattacharjee. He says, my request to you is to enlighten some logic of using vitamin D supplementation for COVID-19.
Right, vitamin D is good for any respiratory disease, why are people talking about vitamin in summer? That in summer, you will not see the virus. The basic understanding is that in the summer, the heat will be more. You will have more sunlight, especially on the higher latitudes. You get, low sunlight. So as the summer comes in, sets in, people go out and they bask in the sun. So what it happens, what you are actually exposed to, vitamin D, more vitamin D. Vitamin D itself is actually an immunobooster. And it has been shown in a lot of papers that a certain amount of vitamin C, the role of vitamin D actually prevents chest infections. In fact, in influenza, there are a lot of studies. And there are two studies, very recently, two studies have come in sharing the view that there are two markers, cathepsin, and these are two cytokines, which are pro-inflammatory cytokines. They get depressed with vitamin D. So Angshuman, I believe this Angshuman is from Agartala?
I will not be able to say that. Dr. Anshuman, if you can speak. Can you speak? Not able to point out.
Angshuman is a very uncommon name. He's my student, actually.
Yes, he is. He says Jaima, sir.
Jaima, yes. So he is one of my best students and a prolific...
You have to unmute himself to speak. Dr. Anshuman. Yes, he can speak now.
Angshuman, are you there? I want to hear your voice.
Yes, sir. Dr. Anshuman, please speak. You are unmuted now. We can hear you if you speak.
Anshuman, the vitamin D receptor is expressed in the immune cells. You know, the the B cells, T cells, all the antigen presenting cells. And these immunologic cells are also capable of synthesizing the active vitamin D metabolite. The vitamin D has to be always with the effect of sunlight and the dehydrocholesterol from the skin. So it acts as an autocrine manner in local immunological milieu. So vitamin D can modulate the innate and the adaptive immune response. And the deficiency of vitamin D is actually increased, associated with increased autoimmunity, as well as increased susceptibility to infection. So that's the reason supplementing vitamin D might help you. There's no harm until you don't do any vitamin D toxicity to the patient. Mind you, it's a lipid soluble. But I would have loved to hear your voice, Omshuma, that in the time of COVID-19, you are safe in Agartala.
You can speak up, Dr. Anshuman, because you are unmuted. We can hear you if you speak. Must be some problem with, otherwise he is unmuted and he could speak.
So did I mean, otherwise to the entire audience, was I clear about what I was trying to say?
Yeah, we have to unmute them. Next question we'll take, sir. Let us take from Dr. Sharad Gaikwad. You will also have to unmute yourself to speak out. Otherwise, I'll check with you the text that you have sent us.
You have sent a question?
Yes, Dr. Sharad. You can speak, please, Dr. Sharad.
The problem with the sound, no? What is his question?
Dr. Sharad was a question of Dr. Sharad. I'm trying to find that out. It's gone way up in the chat box. Meaning hand raised so that we can take the question. We have a very senior person with us, Dr. G.S. Garewal from Delhi. But I don't see him now in the question answer session. He was with us and he had given a very good comment. Sir, if you'll allow me, I'll just read that out for you.
Please.
So he is from the Geriatric Society in New Delhi, Dr. Bobby Garewal, Dr. G.S. Garewal.
Yes, I know.
Yeah. So he says the minimum should be spent on treatment of COVID. More important is the multiplicity of problems in the 80% positives. What all need to be done at home, parameters to be checked at home. How can a GP protect himself?
Yes.
How much is difference in viral load among asymptomatic versus symptomatic patient? Is that a bearing or transferability of infection? And then he says, wonderful speaker.
No, the variability of the viral load, there's a big question. It is all about the expression. Suppose you can have a low viral load, yet your expression might be a little different. So this virus is actually giving us this kind of a thing. In fact, after that, what they're talking about is that the stool, your viral load in the respiratory tissues, fluids, you don't get it, but still it is available in the stool. So there are reports coming in like this. So there's a huge immune modulatory pathway. So people are talking about the interleukin-6 that the tocilizumab and the antivirals. We are talking about because of that immune. The viral RNA code is again very difficult to find. People say that. Hello.
We have Dr. Amruta Neje. You can speak, please. We can hear you.
कोरोना के इन्फेक्शन में ब्रेथलेसनेस क्यों होता है और लंग्स के साथ एक्चुअली क्या होता है, ये मुझे पता करना था.
देखो, एक तो है हम जो बोल रहे थे कि इट इज अ डायरेक्ट इन्फेक्शन, लाइक यू हैव अ ड्रॉपलेट और आपका हाथ से नाक पे गया, इधर से अंदर नेजल म्यूकोसा से. The first part is the throat, the upper throat. So you have a sore throat. Then you start local उधर cytokines निकालता है तो बुखार जैसा लगता है. उसका डायरेक्ट इन्फ्लेमेशन चला जाता है आपका लंग्स में. लंग्स का बेसिक यूनिट क्या है? एल्वियोलस है. तो एल्वियोलस जैसा द्राक्षा फल जैसा है सब, and it has air. So air will come into the last bit of alveolus, and on the lining of the alveolus उसका capillaries है. वो alveolar के capillary membrane का ट्रांसपोर्ट होता है. आपका बाहर से जो कार्बन डाइऑक्साइड आप लिए मैंने शरीर का वो निकाल जाता है इधर से, और आप जो अंदर खींच के लेके आते हो ऑक्सीजन, वो ऑक्सीजन एब्जॉर्ब होगा मैंने मेम्ब्रेन से और अंदर जाएगा शरीर में लंग्स का माध्यम से हार्ट होके। तो नाउ दिस ये वायरस इनका जो प्रॉब्लम जो द इम्पोर्टेंट पॉइंट इज उनका सिक्रेटरी कैपेसिटी बढ़ा देता है। हमारा ये जो सब अंदर म्यूकोसा है, म्यूकोसा सिक्रेशन, जैसा नाक से हमको हर टाइम हमको नाक में पानी आ रहा है, हमको आंख में भी पानी आ रहा है, आंख का पानी हमारा नाक का एक नेज़ोलैक्रिमल डक्ट से अंदर चला जाता है, उधर से हमारा थ्रोट में चला जाता है, मालूम नहीं चलता। नाक का भी वैसे ही चला जाता है, तो भीगा भीगा रहता है हर टाइम। लेकिन जब ये वायरस आता है तो इन्फ्लेमेशन करता है, वो इतना हम बोले ना साइटोकाइंस, उनका उनसे इन्फ्लेमेशन होता है और बहुत जो सिक्रीशन वो गाढ़ा हो जाता है, और उसमें पस सेल्स माने न्यूट्रोफिल मैक्रोफाज सब आके थिक बना देता है, विसिड म्यूकस हो जाता है। तो लाइनिंग वॉल में जो पतला ऐसा था पानी जैसा, अभी ये अटक अटक के जम जाता है, और उनको भी निकालने का एक तरीका जो जीने चाहते हैं तो सिक्रीशन उसमें भी ज्यादा सिक्रीशन होता है, वो पानी भीग जाता है नीचे बेस, मैंने बैठे हो तो ऐसा ग्रेविटेशनल में वो पूरा फैल गया, भर गया, और आप सांस नहीं ले पाते, क्योंकि वो जो ऑक्सीजन अब डायरेक्ट तो जाएगा, ऑक्सीजन वो कैपिलरी में आएगा, अभी वो पानी की वजह से वो टच नहीं कर पा रहा है कैपिलरी।
Dr. Pallavi Majumdar, please unmute yourself to speak. You have raised your hand. Please unmute yourself to speak. Dr. Pallavi.
Hello?
Yes.
Yeah,
I can't hear anything.
Yeah, come again, please. Now we can hear you. You are unmuted. Is that Dr. Pallavi?
No sound?
hello.
Yeah.
Yeah.
My question is that fermented food are safe or not?
Pardon?
Fermented food are safe or not, like curd, paneer, etc.
Fermented food, curd.
Fermented food.
Yeah.
Fermented food for specifically for corona.
Yeah.
Yeah,
You know.
yes.
Yeah, very good question. That's a very good question. You know, we talk about fermenting of anything that also boosts your immunity. You know that. And we talk about gut microbe. You know, gut microbiome is perhaps a very important chapter today to talking about how to boost up your immunity system and minimize the risk of infection. So I don't see any reason why you will not have the kind of fermented food that you're talking about, and whether it's yogurt or we talk about the short chain fatty acids going down as a retrograde food. No problem. I think no problem. In fact, the omega-6, omega-3, all these expressions are exaggerated. Fermented food is actually a good thing if it is to that extent fermented that it doesn't cause harm and it's stale and other things. But there is a big benefit of the gut microbiome and the digestive system enhancing the immune system. Pallavi, was I audible?
Yeah, yeah.
The probiotic, the probiotic part, the safety and preservation part, you have to take care. That is, you cannot keep it in the open for the night, and that kind of fermentation we are not warning. But if you take, like, say, for example, even Tabasco sauce is a fermented product, yogurt, the soya sauce. The rampant use of soya sauce actually enhanced the longevity of the Chinese population because of the fermented. So it's a good question that you asked, and I can continue. This is my, from diabetes awareness and you, these are my areas of passion. So
there's another question by Dr. Tanveer Fatima. She has asked you, does intravenous supplementation of vitamin C help in COVID-19 patients?
She has bowled me out. I mean, I had no clue that whether this might be, first of all, why would I give a molecule which is water soluble in the IV form? And I will just ask you to have the tablet chew it, it will get dissolved, and that's a dietary supplement. So I will not want you to have an IV supplement. And if you have an IV intravenous, maybe some trials will have it. I have no clue whether this kind of a thing, first of all, exists for human practice. If it does, then I don't think, apart from apart from trials, there is
Dr. Tanvir, if you would like to talk about something, what Dr. Saab is saying, if you want to say something, probably.
Can you tell me, because intravenous, there is a supportive care only for cancer patients. And I don't think that for our kind of a group of elderly, just ascorbic acid supplementation, if you do it on a regular dialysis treatment patient, well, there are, I think there are papers, and for cancer, but not to, high dose of vitamin C you can give to, for preventing corona, for any antioxidant you can give. Linus Pauling gave us that antioxidant we don't really use.
We have 3 hands raised. Dr. Ruby, you wanted to speak? Dr. Ruby Datta?
Hello.
Hello?
Yes.
Hello, sir. Can we take a raw fruits and vegetable during this time?
You can, provided you safely wash and rinse and cleanse, and your potassium levels, etc. Then why not? That's the best thing.
We have Anis Fatima. You can speak, please.
Yeah. Hi, sir. Can you hear me?
Yeah, I can hear you.
Yeah. My question is, as you D plays an important role in immune boosting.
Pardon?
Vitamin D will play an important role in immune boosting.
Yeah, that's what I said now. What's up? Didn't you?
Yeah. So because of lockdown, we are not able to get it from the sunlight. So is it okay to take the supplement?
I don't mind, because I will always say that 60,000, 60,000. It is your actual optimum requirement is 2,000 international units.
Yeah.
So if that is in a month, it's a 60,000. You have 1 capsule, and then whether you can go out in the sun, or whether you can, have your egg and other from the food you can have. Then why not?
I'm Dr. Surendra Gupta from Ludhiana.
Okay.
Actually, Dr. Basu in the beginning saluted the senior citizens. So I also salute all our senior citizens who are at risk during these days. But in last 30 years, we have progressed a lot. And in those days, a song was there, जब हम होंगे 60 साल के और तुम होगी 55 की. So now we see a lot of people of 70 doing jobs and all that, and now people above 80 are considered to be elderly. So we have come a long way in improving the longevity in India.
Absolutely, sir. I fully agree, because today there is a concept called lifespan calculator, and as these girls were talking about vitamin D and vitamin C. जो भी है, I am a young 55-year-old boy. I have not become a man.
I am 64-year-old boy, and quite young, and
तो the thing is, ये मन का बात है, ये अंदर का बात है. How free you are, how happy you are is actually the best marker for your age. That's how I believe. If I think that I'm doing good to people and I need to live for good reason, there's no pain in my heart for any other reason. Survival is just a very simple flow.
Dr. Rashmi Joshi, she wants to speak.
This is Dr. Rashmi Joshi from Indore. First of all, thank you so much, sir. It was a very informative session and very seat-boltingly carried out. Thank you so much, sir. I have got a couple of questions. Basically, I'm a dietitian, and I want to know two of the things from your side. How would you explain it? The role of dietary protein in protection against COVID. This is my one question. Second question is, how can soda bicarb there is a thing which is going on that you can wash your vegetables and fruits by soda and adding soda into your water. And how much is it safe for a hypertensive patient? Doesn't it penetrate through the membranes of the fruits and vegetables? These are the two questions. You can take it on your own.
Okay, so as of the protein part of it, we are sure that we have known in our past medical school days that whey protein has so much to contribute to immunity, right? Whey protein, for that matter. There are so many papers in our college, in the school days. And so if it is not an animal-based protein and you are otherwise safe, then we know that the cysteine, the glutathione, and the antioxidant stress that comes from glutathione to the protection of many diseases. Glutathione, the antioxidant role of it. So that comes from whey protein, cysteine and glutathione. So, and of course, the benefits of protein like muscle strength, anti-inflammatory power, even the bone strength, the antioxidative stress, antimicrobial, immunoregulatory, anti-diabetic, anti-hypertensive, whatever. In fact, even the cognitive, all wound healing is from protein. So, if you are damaged by a virus, that is a wound, then this will become good. And the alpha-lactalbumin, these are the things that have been helping us all throughout. About your, the baking soda thing, and I personally believe that it's when a cleansing, say for example, I go out and I meet a COVID-19, come back, I have this 1% sodium hypochlorite, which is there in the toilet. And, my wife, she makes sure that I throw it, and she has her own arrangement. She puts it in. We have now one washing machine, which was actually, we thought it was not working. But luckily, Corona has made it work again. So it's specially to wash my clothes when I'm coming back I'm from the Apollo group. So we are actually an official, COVID-19 treatment center. So more than anything, they are doing it. But baking soda, the baking soda, one of the Zori bicarb that you're talking about, it is very inexpensive and it's a good way of cleaning as well. But if you are hypertensive and you have kidney issues, then I think you must be careful to rinse it, like the way we ask you to, leach that, overnight, soaking it in, soaking any vegetables, raw vegetables or fruits in, say, salt for more than 4 hours, or in some vinegar. This will also be the same. So I don't think you need that. Most important is soap. Detergent is actually the worst offending agent for this virus.
Okay. So can we soak? Hello, can you hear me? Yeah. So can we soak vegetables and fruits in detergent? That is what you're suggesting?
No, I'm saying that. In fact, I tell you, my father is 91. He's a vice chancellor of a university. He's called a king of the plant kingdom. So that man, I know, he has a bean bar at home, and every time he gets the apples and the peel, all the peeled fruits, he will not peel it. Before depeeling it, he will actually wash it with a bean bar and then completely rinse it, keep it in 2 hours in salt, and then, because he is the man behind throwing out GMP from this country and genetically modified, so he knows about the impact of all these the pesticides and the bioactive amines.
We have Dr. Manoj Gadia. Introduce yourself, sir, and speak.
Hello, good evening, sir. First of all, thank you so much, sir, for precious time for give us a knowledge. Sir, I have 2 questions. First question, sir, what is the relationship between quinolones and diabetes? Because I see a 2-3 patient, when they give, the physician will give the levofloxacin for UTI, and then suddenly they are coming for the sugar of 32 and have hypoglycemia like that.
Yes.
And
it has been shown that fluoroquinolones, they have caused even fatal fatal hypoglycemia. So that is, I was talking about this impact of the hydroxychloroquine causing this hypoglycememia. Similarly, you have in fluoroquinolones the impact of hypoglycemia. There's a pathway by which it affects. So it has factor, and also if you are the other way, if you are exposed to fluoroquinolone antibiotics, it is postulated that that acts as a risk factor for development of type 2 diabetes as well. So both way it works. And there are fundamental mechanisms here. But we know you are absolutely right. Levofloxacin causes hypoglycemia. We have seen that. And even the drops, the worst part is, gatifloxacin drops, eye drops. They caused, hypoglycemia, because this is fundamentally because insulin is released by the blockage. You are a medical doctor?
Yes, sir.
Achha. So good. No, I'm just asking this because why does this happen? If you want to know, then I can explain it to you. It occurs primarily, as I said, it can both. You can have severe hypo and hyper with gatifloxacin and levofloxacin, but usually you do not get it with ciprofloxacin. That's a safe bet. But there are mechanisms by which it happens, and you should ideally avoid gatifloxacin totally. Levofloxacin is a good antibiotic for UTI and even GI, even lung. So you can continue, but keep a check on if the patient is simultaneously having sulfonylurea or any other oral agent which causes this. It's basically a class effect kind of.
Yes. And sir, my another question is, what is the relation between NSAID and hypertension? Because I have seen even one patient had taken 1 tablet of diclofenac, it's lead to produce a hyper blood pressure shoot up like 180 like that. So sir, what about your experience about NSAID and hypertension?
The drug-induced hypertension is something that we often hear about. There's all the drugs are speculative method is they cause salt and water retention. If you go by the pathway of the COX pathway, the arachidonic acid pathway, they cause salt and water retention. So that is the problem. And the moment you have that, the COX-1 and the COX-2 enzyme.
COX-2 inhibitor, yes sir.
So they actually, finally the reduction of prostaglandin formation will happen. So that's how pain will come down, or inflammation will come down. And the NSAIDs cause dose-related increase in sodium and water retention, which actually gives rise to hypertension. And we know that the COX-1 is in the glomerulus and the afferent arteriole. COX-2 is only in the afferent arteriole and the podocytes. So there are specifically locations in the kidney and the glomerulus where the vasodilatation of the renal vascular bed can occur. So there is a lot of renal vascular resistance can occur and increasing renal perfusion. So एक diuretic natriuretic effect उनका होता है, उसका साथ they cause this, by the natriuretic effect they increase sodium retention करते हैं पीछे जाके feedback mechanism करके, and they have the vasoconstricting factors like endothelin 1 gets activated, which all finally gives rise to hypertension, can give rise to hypertension.
Okay. Thank you so much, sir.
This is a path.
We have another hand raised. Sir, hand raised by A.K. Gupta. Would you like to speak?
Dr. Deepika, can't we have a cup of tea, all of us? A virtual cup of tea?
That is one thing we'll all miss. These kind of seminars, not possible to have it in webinars.
This is the time that I'm at home and I'm the only thing that do at home is I'm supposed to make a cup of tea for my wife, who's slogging out the entire day, going to the hospital, cleaning the toilet, to mopping the floors, making good food for us. But the tea is something that she would like to deserve from my hands. And I was trying to do it quite ably.
So we take this by Ms. Dr. A.K. Gupta. The last question we are taking. Dr. A.K. Gupta, your hand is raised and you are able to speak. Please speak. No, he's not speaking. although he can talk. Would you like to say something, A.K. Gupta, sir? No, we are not getting the audio. So I think there are very many questions over here, but then as time we've already taken is over 1 hour extra. So shall we call it a day, sir?
Yeah. I'll be glad to say that we are waiting for more questions, and we should continue respecting our elders and making their lives beautiful. We would take always as we live. We should look up to our seniors to get their guidance, and that's how life is all about. So
there's Dr. Perela Ajay. He's saying role of convalescent plasma in COVID when we should initiate.
Pardon?
Plasma.
Plasma in?
In COVID, when should we initiate?
No, this is when you need treatment. I mean, this is for when the patient has got the infection. The plasma therapy has started in Texas. So the initial trial has started in Texas. And they also started it in China initially. But the overall, India also starts to, they are talking about this plasma therapy. You have your own, suppose I'm a healed COVID-19 case. I'm a healed, this is a convalescent plasma, which is there in my body. So they will take that plasma. They have shipped so much of plasma, China to Europe for the treatment part. So this is called the convalescent plasma. It is a potential. It was there for SARS-CoV-1 also, and that gives us enough, and for Ebola also. So it is an empirical treatment during the outbreaks. For Ebola, it did like that. When you start is when you are having that, you are actually actively having a disease. So that's a possible explanation where you can already have antibodies. You are injecting directly antibodies to suppress the viremia. If you have a high viral load and you know that the antibiotics will take time, these antibodies already produced antibodies are going in. So you have a primary immune response being given exogenously from outside.
Perela Ajay, sir, this question's been answered, and there are 2 more questions you've asked. Would you like to speak? You have to unmute yourself to speak. Perela Ajay, your questions have been taken just now about the plasma therapy, and now he's asked 2 more questions. One is remdesivir available in India by when we should expect, and the other one is, shall we give ivermectin 1 dose empirical in COVID?
I will not comment on ivermectin. India, yes, India, we have remdesivir. Indian drug makers are doing it. The available part, I think I'm in my hospital. Apollo has procured this, but we know that there are Dr. Reddy's is Cipla, Dr. Reddy's and Glenmark, I think. They have started doing this. This is with the US-based Gilead Sciences that they're doing it. I think that is what it is.
There's a question from Dr. Umesh. But Dr. Umesh is not there now with us. He's asked a patient on HCQs and ACE inhibitors is somewhat refractory to COVID infections.
Refractory.
Yeah, refractory.
If that's what I said. HCQ has been talked about as a prophylactic by Mr. Trump. But that was a very cavalier commentary made from that small French non-randomized clinical trial. I do not know what statement he made and what inspired so many companies to. And in fact, also there was a modification, not a modification, a modification of the stance of not exporting HCQs to foreign countries. Suddenly overnight that stance was changed, and we had to do 29 million tablets. We gave it to doses. We gave it to the US. But I do not support that this will be a prophylactic molecule in any way. What I apprehend is if you're doing it, you can actually unravel the hidden arrhythmia part from an elderly or a heart patient. You can actually get a malaria resistance in the future, in the pipeline, that can happen. Frankly, if you ask me, I'm not particularly keen on having HCQ like just a pop in a vitamin C. No.
Okay, one more hand raised. That is Dr. Shivashan. Would you like to speak? Please unmute yourself. Shivashan Mugam Arugam. Please speak.
Hello.
Yes.
Hello. Good evening, doctor. I am in-house of this Jackson Paul. I am not a doctor.
Okay.
So I wish to ask some questions in this regard. So really, I am thanking very much to you because I have understand such a wonderful way to COVID-19 and associated with the coronary cardiovascular disorder. My question
You're
number
from
one.
Jackson Paul.
Yes, sir. Yes, sir.
You must give.
Our sales team.
Okay, you must give from my behalf a special cookie to Vipin. Yeah, tell me.
Hello, sir. My first question. You said that the azithromycin first 2 days, the patient, those who are affected in the COVID-19, azithromycin with the paracetamol for 2 days.
No. I said the dose will be reduced.
Okay.
Dose will be reduced if you are giving it with a hydroxychloroquine because of the potential chance of the arrhythmia. Because HCQ also causes QTC prolongation, and this torsity pointy and everything. HCQ.
Okay, sir. Then you talk when we are talking about the RAS system, that is the radio RAS system. You talk about the ACE angiotensin converting enzyme. So that is the ACE has to convert into angiotensin 1 and angiotensin 2, and ACE 2 will be into the angiotensin 1 to 7, and ACE inhibitor as well as the ARB. Along with that, we have to recommend these coronavirus drugs, which we have as of now recommended by the WHO.
Now, pardon, WHO has given.
WHO, see, as of now, because some of the drugs, like azithromycin or in the hydroxychloroquine, likewise the drugs, some of the drugs are recommended for the treatment of the COVID-19 throughout the world.
Yes.
So, what my question? The elderly patient, those who are affected, the cardiovascular or diabetes patient, along with the as usual, that is ACE inhibitors, ARB or calcium channel blockers, beta blockers, or in the anticoagulants. Along with that, these drugs also has been recommended, including hydroxychloroquine. I am asking.
They are.
They are okay. Why, doctor, not recommended any injectable form? Because this is major of associated with the respiratory tract infection or in the respiratory infection. Why injectable like the clostridium sodium or tetracycline not recommended in the?
Yes, very good question. I was just telling somebody. I think Dr. Deepika heard me saying that why not the role of doxycycline?
Yes, sir.
Yeah,
Yes,
you're absolutely right. You are absolutely right. I fully believe, because they have again the same mechanism and even more in terms of immune respiratory mechanism. They have.
Yes, sir. Yes, sir. Yes, sir.
I will agree with you. And doxycycline has profound roles. If you remember, in our college days, we had doxycycline for so many atypical, chlamydia, etc., etc. So yes, you are right. I fully agree with you.
So thank you so much. We come to the end of our session now. And there have been so many questions, sir, which we have not been able to take up. Some of these attendees are not there for them to take it up. Like there was a question about the psychology, how it is being affected of the elderly, because of the corona, the mental health of the elderly. So,
very sad. Very sad. It is already over. Otherwise, I could have,
Yes, that is one topic which is to be taken up as a separate issue, which you could have taken up very well. But then, sir, I would like to inform you also that this Sunday we are having another webinar in which we are taking up the impact of COVID-19 on the elderly. Focus is on mental health, and we have the speaker from NIMHANS, Bangalore. That's Dr. Debanjan Banerjee.
I saw that poster. I saw your thing. Yeah.
Yes, sir. So we have this another one coming up, and I have posted it into this chat box. I have given even the link. If any of these attendees, if anybody is interested, they could join over there and uh, get registered, and we could all meet again on Sunday.
Wow.
So it is like this, that because of these webinars, we are able to share the knowledge, and that is the purpose. The Jackson Pal purpose is this, that we come together, share knowledge from one doctor to another, and have some discussions, and we improve on whatever treatments can be made available. So the medical advancements everybody has to learn about, and learning is a process, keeps on going. So thank you so much, Dr. Debasis Basu. We are really privileged that we had you here today with us for over 2 hours. And thanks a lot for so much of knowledge sharing. From the attendees side also, I say this, and also from our side, a wholehearted thank you and goodbye to all the attendees. We hope to see you soon, maybe next Sunday, this Sunday, which is coming up. Thank you, Dr. Saab. Thank you very much.
It was absolute pure pleasure.
Thank you. Bye.
And I thank all of you to take so much of love and labor. So I think it all comes for a good reason. Thank you. Thank you.
Thank you very much. Bye-bye.
Bye. Bye.
Thank you.